Who wants to talk about fractures? I do. Let's dig into what happens when our bones are exposed to more force than they can tolerate. So this is at the very end of the line of that stress strain curve in terms of the maximum amount of strain that it can tolerate prior to failure. As we've talked about a couple times already, that typical strain point is around 2%. And so it doesn't stretch or deform a whole lot prior to failing. In part, what will decide its failure point will be the direction of the force applied. And that goes back to talk about anisotropy, where bones are really good at withstanding forces longitudinally, particularly with compression, because that's what we have to tolerate all day, every day in response to gravity. And anytime we're carrying anything, we're compressing forces or compressing our bones in line with that axis. So this is very much an exaggeration. We have a normal bone, so at length 0, and when we tension it, if we were to stretch a bone, we end up elongating it. Certainly not to this amount where there seems to be a several inch change in bone, as bone doesn't tolerate much strain prior to failure. Same when if we compress a bone. Again, we won't see this multiple inch change in our height when we put weight on our back when we were to do a back squat, for example. But do know that they do tend to change, but these are kind of units of microstrain, so very, very small amount of change that will happen. Going back to tension, this isn't a very common mechanism. The only kind of scenario would be maybe with bungee jumping, where essentially we're lengthening our height and we're applying a tensile force on our skeleton, or some sort of medieval traction torture device where we have somebody cinched up and we're kind of cranking them to kind of stretch some answers out of them, for example. Compression is by far the more common of those two stresses. The weight of gravity, the weight of us carrying things will cause our bones to compress. In response to that, what we end up seeing is that we see compression happening in the same direction of the load. What happens perpendicular to that load is that we end up having tension. And we see this all the time. If we were to compress a balloon or stand on a basketball, what we would end up having is deformation happening in line with gravity, and we would have tensioning happening perpendicular to that direction. When we get into bending, shear, and torsion, things are a little less straightforward. In bending, what we end up happening is that we have this kind of angulation that occurs. As a result of this, we have uneven distribution of forces, where we have compressive forces on the concave side, and we have tensile forces on the convex side. And what we know when we're talking about these combinations of forces is, again, due to the viscoelastic nature of bone and the anisotropic nature of bone, bones are strongest with compression and weakest with tension. And so as a result, the bone will be able to tolerate the compressive loading, but instead we'll have failure happening on the tensile side of the bone. And that will be highlighted in the next slide. When we're dealing with shearing forces, what we have is that we have two sliding forces occurring in opposite directions. And again, because the bones aren't designed to withstand medial lateral forces, because they're designed to withstand superior inferior forces, is that we end up having failure as a result. Certainly, bones aren't designed to withstand torsional forces or twisting or rotational forces, depending on what you read. And so this causes force cause compression and tension along the longitudinal axis and shear in the transverse axis, which we'll talk about what that looks like when we actually do fracture. I want to emphasize that in reality, this doesn't happen in terms of how dramatic this shows. Our bones aren't super elastic, so we're not going to see this crimping up nature. Essentially, they would fracture far before this were to happen. Same for why we don't see a multiple inch change in our height or why our bones don't bend to 45 degrees prior to failure, because they only fail after a couple degree change of strain. So do consider that these are very much exaggerations. In bending, we again have this asymmetrical loading pattern, where on the concave side, we have compressive loading, and on the convex side, we have tensile loading. Stresses are higher the further that we are away from a longitudinal or neutral axis. So you can imagine this is the long axis of the bone, and the further we are either towards the tensile side or the compressive side, the greater amount of tension or compression we're going to apply. And this is as a result of torque. From what you remember of torque back in maybe grade 11 physics, is that torque is the force times the lever arm. And so the longer the lever arm, the greater amount of torque, and thus we're going to see greater amounts of tension and compression. Again, because bones are designed to tolerate compressive load, we'll tend to see failure happening first on the tension side. When failure does occur on the tension side, we'll end up having this very clean cut. And so you'll see an x-ray later of what a stress fracture looks like, which is on the tension side of a bone fracture. And it's a very clean, distinct, sharp looking line. Versus with compression, what ends up happening is that it ends up fragmenting into a bunch of little pieces. And so why I'm telling you this is that when you start interpreting x-rays, you can start getting clues into the direction of force, the magnitude of force, and then that will also tell you what side of the bone was the tension versus compression side. When this happens, we can start putting together a bit of the forensics behind what happened to this person. This is certainly important when you're dealing with some sort of post-mortem examination of a body and be able to figure out what the mechanism of injury was or mechanism of death. Or in the case of domestic abuse or child abuse, where the x-ray might not line up with what the parent or the spouse is saying with what happened. And then you can start probing further and maybe initiate an investigation if essentially you're seeing injury in line with a compression, but they're subjectively telling you that it was a traction injury, it was a freak accident, but in reality you're suspicious otherwise. So important to know. We talked about bending. So bending forces aren't great because again, it helps to, or it causes asymmetrical loading on the bone, with half of it having to tolerate compressive forces and the other half having to tolerate tensile forces. In the event of 3-point bending, what happens is that we have loading happening on one side where there's kind of two forces applying force in one direction, while we have only one force occurring in the other direction. So as a result, we end up having fracture happening right down the middle in line with the single force happening. You can see here that with this skiing example, we have two vectors going forward, momentum or inertia is carrying them forward, and then we have this bending vector happening opposing those two. As a result, if the force was higher than the bone's capacity, then we would end up having failure happening in line with this arrow. For 4-point bending, we have two forces opposing each other. As a result, instead of getting a nice clean break right down the middle in line with the one vector, instead we get this shattering happening all the way up and down the bone. And so hopefully this is starting to give you clues that when you see this, you can guess the magnitude and direction of force. So here are the types of fractures. So we have a transverse fracture, and essentially the name kind of tells you what the directionality of the fracture is. So transverse is happening transverse to the long axis of the bone. So it's essentially happening at a nice clean 90-degree angle to the bone. A linear fracture is happening along the long axis of the bone. An oblique fracture, you can imagine, is happening at an oblique angle to the long axis of the bone. This would be a non-displaced fracture because the two ends of the fracture are still touching, as opposed to displaced where we end up having separation of the two ends of the fracture. And we can get non-displaced and displaced of really any of these fractures, particularly transverse. We can have non-displaced, we can have displaced. We can also have a closed fracture where the fracture is still within the skin, versus an open fracture is when we break our bone and we have a bone sticking out of the skin. And I was tempted of having lots of pictures as to what open versus closed look like, but for the people with sensitive stomachs, I decided to withhold that. But if you're curious, then you could easily Google that and see lots of bones sticking out of cleats and such. Then we have spiral fractures, which are these quite pretty looking fractures in a sadistic way that follow this oblique line, but essentially wrap around the bone. Then we have a green stick fracture, which is a really unique type of fracture that happens exclusively in kids. And this is because we learned earlier of how the collagen is very disorganized initially. And so because of that, it can withstand forces both on the compressive and tensile sides because they haven't essentially created this lattice kind of hashtag presentation yet. So as a result, there's this bending mechanism that causes it to microfracture without macrofracturing. And why it's called a green stick is that if you were to try to yank off a branch from a tree and then try to break it in order to put it into your fire pit, and you try to bend, and it kind of, the bark starts peeling off, but otherwise you can't break it. And that's the equivalent to a green stick fracture, where it's still so young that you can't actually fracture, which is protective for children. A comminuted fracture is what happens when there's either a mass amount of force, usually as a result of mass amount of force, where there's all these fragmentation happening of the bone. And so it's essentially when there's greater than 2 fragments is when there's this comminuted nature of the bone. So 3 or more pieces of bone is considered comminuted. All right, so first on the to-do list is transverse fractures. So again, we have the bone breaks at a 90-degree angle to the long axis of the bone. The mechanism of injury, or MOI, is angulation or a blow directly perpendicular to the bone. So this causes pure bending. If I have the bone and I apply a purely perpendicular force, then I will get pure bending happening, which then will cause a clean horizontal line. Or what will happen is in the event of traction injury. So maybe that bungee cord example, or pulling too hard on a kid's arm to kind of pull them out of trouble might cause this type of fracture. So as a result, the bone does not have to be weight bearing at the time of fracture. Essentially, I could have my arm like this, and then someone falls on my arm. I'm not weight bearing through my arm, but then I get a transverse fracture. With an oblique fracture, it's essentially the same mechanism of injury for a transverse, but the angulation is not a pure 90-degree angle. It's either an angulation from above or below that will cause this uneven bending mechanism of injury. We'll also see this if a massive axial load will occur to our femur. So you would think that would just maybe cause some sort of crush injury, maybe a comminuted fracture, but it's again because of the anatomy of the bone, where we're not purely loading it up and down. Instead, because we have this femoral head and neck, then when we apply, we have this bending mechanism. And because it's not this pure bending, we'll end up getting this oblique fracture that will occur without apparent angulation. With a butterfly fracture, what will happen, and this might be my favorite, if not the spiral fracture, just because it's so unique when you see it. Sometimes hard to identify, but it's unique when you do see it. So it's again as a result of 3-point loading. So we have here, and we apply forces here, and and then one opposing this way, causing this bending mechanism. Will also occur with some sort of pivoting around an object. So in the event of that skiing example, where the leg is pivoting around that rock that the ski has hit up against. Or in the event of a dashboard, where momentum from inertia will pull us into the dashboard with a motor vehicle accident, and then our leg will essentially pivot around the dashboard. Again, how the fragmentation happens will dictate whether it was a low speed injury or a high speed injury. So if we get a non-fragmented wedge, which this would be an example of a non-fragmented wedge, really in either of these scenarios, then that would be a result of low speed bending. When we have a fragmented wedge, where it's this triangular bone that is divided into a million different pieces, then that's a result of high speed bending. So you're walking down the street, and then we have a low car that just takes out your legs, and that would have caused that bending mechanism or 3-point loading of your femur. Usually this occurs from two oblique fracture lines meeting to create a large triangular or wedge-shaped fracture. So we spoke last about the oblique fracture. So this would be one fracture line followed by another fracture line that meet at a common point. That initial point of failure will be on this side of the bone. And that's because this side of the bone is the tension side. And like we've been saying this whole time, bones can't withstand tension as well. And so it will fracture here first and then splinter in these two oblique lines. When that happens, then it will leave a triangular or wedge-shaped piece of bone as a result. What's really interesting is that the wedge often points in the direction of the moving vehicle or the force. So we see here we have 3-point loading. This person would have been weight bearing at the point of injury. And then let's say a soccer player or football player takes out their legs from this perpendicular angle, which then would have caused compression on the concave side and tension on the convex side. Because bones are weaker in the tension side of the bone, we would have gotten initial failure happening here at the point of this wedge. Then we would have had two immediate kind of splinters happening out at kind of these 45-degree angles to this, which then will leave this wedge happening in its peril. You can also see here that we also have a fracture of the fibula happening here, and it looks like a comminuted fracture because of there's this random piece of bone floating next to it. So this helps to identify that this would have been a high velocity or a high force tackle in football, because we start to see fragmentation happening up here, as well as it will show us the direction of travel. So if this person were to show up to an emergency room unconscious, and then the orthopedic surgeon were to x-ray this, they would be able to guess with pretty good certainty as to what happened, even prior to asking the person once they were to wake up from their surgery. And that's just based off of the fracture pattern. So spiral fractures. So the mechanism of injury, or MOI, is torque. So rotation about an axis. So it is directed along the axis of the limb. So the long axis is vertical, and we're twisting about that long axis. Usually this results when we have some sort of long lever attached to us. So skis, snowboard, ice skates will all increase the lever arm, which then will increase the amount of torque acting on our skeleton. This can result as well as from non-accidental trauma, such as child abuse, kind of grabbing and twisting a child's arm, unfortunately. A fracture initiates at some point in the bone and then travels at an angle at approximately 45 degrees with respect to the long axis of the bone, around the shaft in the same direction as the applied force. So if the bone is traveling clockwise, then the fracture will occur at one point in the bone and travel at a 45-degree angle clockwise as it spirals up and around the bone. Once the fracture has completely encircled the bone, the shaft becomes so unstable that a longitudinal fracture line develops between the proximal and distal ends of the spiral to connect them. So let's look at this picture here. We have a random point of failure within the bone. Then we have a 45-degree angle occurring from that in the same direction as the applied force. That will encircle the bone all the way until essentially the proximal and distal ends of the bone or the end points are essentially standing on top of each other. So straight in line. Then the last part of it will be to connect these dots and create this kind of infinity symbol by doing that longitudinal fracture line that will connect the proximal and distal ends of the spiral. And so you can see it creates these really sharp and clean lines vertically. And then you can see that this straight longitudinal line will be to connect the proximal to the distal end of that spiral. These can be hard to diagnose because from here, it kind of looks like maybe two separate oblique fractures. It might look also like a wedge fracture. So you need essentially two dimensions to look at it. You need two different angles in order to be able to properly diagnose it, unless it is essentially non-displaced, where essentially you see it on X-ray to present similarly like this. So really for any fracture, for any dislocation, you need essentially two angles, maybe even three, to be able to identify direction of injury, because we don't really get a whole lot of dimension from an X-ray because it's only a 2D image. Comminuted might be the easiest out of all of these to be able to identify. And that's essentially when there's a giant mess of stuff going on. There's all this fragmentation, and it's a pretty nasty looking bone. This is a result of some sort of compression, high compression crushing type injury. So either a result of somebody working in a trade, which then something dramatic and heavy falls on them. Or in this event, I bet that this person was in a car accident where they're sitting with their knee at 90 degrees, and then they might not have been wearing their seatbelt, and then their momentum pulls them into the dashboard with the contact point being at the dashboard, and then the force gets applied all the way through the femur, which then causes all of this fragmentation to happen in through the femur. As a result, we get more than two bones fractured, which then results in it being classified as a comminuted fracture. The higher the energy input, the greater amount of fragmentation or comminution. And you can see there is maybe 20 pieces of bone floating around this person's thigh, and as a result, it suggests a really high energy. There, we have to be careful about these for a lot of reasons. You can imagine these are hard to manage surgically because there's so many pieces to this puzzle, as well as all these different fragments will essentially act as these little razor blades occurring within the body. And so when we have high velocity or a high force mechanism of injury, these will occur really jagged and feathery, meaning they're going to be really, really sharp within our body. Sometimes so sharp they exit our body, they cut their way through their body if you were to move the wrong way and not stabilize the injury properly. As a result, this can cause a huge amount of soft tissue damage. This can cause neurovascular damage. This is where essentially pieces of bone can start cutting arteries, nerves, veins, lymphatic supply, all of this stuff, sever tendons, all because of the shards of glass that they essentially have within their body. If the fragments are fairly smooth, then it might indicate a low velocity mechanism of injury, which also will give physicians or detectives or whatever lots of clues into what might have happened. But from here, you can see this is a dashboard style of injury. The mechanism of injury coming straight here is direction of force, which essentially crushed the femur. And you could even see that it crushed the head of the femur or the condyles of the femur straight off. And then likely, you can't really see from here, but likely they have some sort of tibial plateau fracture as well. So what do we do about this? Very depends. That's the answer. It depends on the bone, because some bones require less mothering than other bones. Some bones have great blood supply, so we don't need as long of healing time or to be as cautious with management, versus some have terrible healing potential, so their prognosis is higher, or we essentially have to jump a couple steps straight to surgery knowing that they're probably going to fail just normal casting or immobilization. So when we're dealing with immobilization, we're dealing with some sort of device that you can kind of come in and out of somewhat at will, where you break an ankle and we don't need to fully cast it, but we should put the person into an air cast. When you put them into an air cast, they can take it out to shower so long as they're non-weight bearing, or with the event of a broken scaphoid, maybe in some cases they'll just put a splint and allow them to kind of air out so long as they're not moving or loading, etc. In some cases, you can break a bone and essentially you're just kind of sent on your way with the instructions of don't do too much, don't load it, don't play sports. This would be the event of maybe a broken finger, maybe a broken toe, maybe a broken rib. There's little that can be done for that. If the two ends of the bones were separated, then we essentially need to do an open reduction. So what that means is that an emergency room doctor or orthopedic surgeon has to see the image on X-ray and then approximate the two ends of the bones without doing surgery. So they just manipulate the bones through the skin to approximate. Then they do another X-ray to see if they have achieved proper alignment. If they've achieved a proper alignment, then they cast around that and then wait a period of 6 to 8, 12 weeks for the two ends of the bones to heal. Sometimes we need to do an internal reduction, which is essentially opening them up and physically putting your hands on the bones to be able to realign the two bones. Usually if they're going to do an internal reduction, what would happen or have to happen is that they would have to, or they would likely do an internal fixation associated with that, where they either put a steel rod going right down the middle of a long bone, which then over time the bones will the osteoblast will essentially calcify bone around that rod, or they'll use kind of standard plate and screws. What they might also do is do an external fixation, which is really bizarre to see. And I'm really surprised that it's an ethical way of doing it, although people do really well, where essentially you have this is called a halo, where they have all these different pins going into the bone from the outside, which I've seen a lot of these in hospital. And the weird part is that these people don't get infected, even though they have essentially open wounds with steel rods going through their skin into the bone. In either case, these people end up doing really well because essentially we have physically told the bone where to go and have kind of locked it in and waited for the healing process to occur over the course of 6+ weeks. And then rehab starts. Sometimes rehab is allowed to start before that point, where we have somebody, let's say in an air cast, and I can't do a whole lot to the tissues or to influence the fracture site, nor would I want to, but I'm able to work above and below that injury site. So meaning if this person were to fracture their mid-tibia and what looks to be their proximal fibula, then I am able to continue to rehab and promote range of motion happening of their knee or promote range of motion of their ankle. I'm not going to necessarily do a whole lot in terms of weight bearing through that side, at least until I get clearance. There's no reason why we can't isometrically strengthen these people while they're casted. So they might not be able to move their joint because their joint has been locked out, but we can to push a little bit into that cast in different directions in order to be able to try to maintain muscle mass. And then we essentially slowly reintroduce weight bearing as the surgeon will allow. So essentially, I'll get a protocol back from the surgeon saying, please initiate weight bearing at partial weight bearing status at 6 weeks. And then at 6 weeks, I'm counting down the days to be able to do that. And then we progress as needed. We have a high amount of remodeling. So this is kind of separate. All that other stuff was in relation to kind of more traumas. What happens in sport, what happens in car accident, what happens falling off a ladder. This is essentially what happens kind of day to day, particularly in older people. What happens day to day is that we end up getting breakdown of our bone to a certain degree, especially after a really heavy workout. We'll get essentially some breakdown just like we will of our muscle tissue. In response to that is that we will get remodeling that will occur in order to be able to fix this micro damage. So because trabecular bone occupies such a great surface area, kind of 20% of weight, 80% of surface area, is that we'll get high turnover of the trabecular bone. In fact, we'll get 10 times greater rate than we will see in cortical bone. And you can see this cute little osteoblast. This is an animation, but cute little osteoblast forming or kind of standing on the horizontal lattice of the trabecular bone, doing its thing to try to remodel the bone. You can see here from little micro cracks and stress fractures due to maybe altered loading patterns is that we'll get some breakdown of this tissue. In response to this, our body has to do something. And so these occur commonly in bone, in both compact and trabecular bone, but happens 10 times more frequently in trabecular bone. Very common in healthy people, particularly healthy older people, where we'll end up having 5 cracks per millimeter squared versus no cracks in maybe you or I. The number increases with age, with females experiencing more than males at a comparable age. This again might be as a result of females lose bone at a greater rate than males do. So we would expect as a result of that, that there's going to be micro damage happening to that kind of weakening bone. This can significantly reduce the bone stiffness and strength and serve as stress risers. And so I mentioned that just in passing, but a stress riser is essentially some sort of microfracture occurring within the bone that will cause the bone to fracture along that part. Just like if you are familiar with tile cutting, if you're laying tile, is that essentially you could, instead of getting a wet saw, you could score the tile with a knife or a special machine that then will essentially just chisel out a really clean line out of it. That way, when you apply a pressure, it will fracture at that line. And that's because that line serves as a stress riser. And so as a result of this, these little stress risers can then lead to stress fractures. So stress fractures occur in athletes exposed to repetitive loading. So soccer, endurance runners, repetitive jumping in volleyball or basketball, etc. We don't tend to see this in swimmers because we're not exposing our skeleton to a whole lot of load. We wouldn't see this a whole lot in maybe synchronized swimmers, etc. False negative rates are really high in imaging. You can see here, this is an X-ray that would have later come back to be a positive stress fracture, but you can't really tell anything's wrong. And so as a result, you'll send these people for X-rays, they'll come back negative. Then as a result of that, they might be tempted to return to sport and be aggressive in whatever they're doing because they're like, oh, I'm negative for stress fracture. But in reality, they've had one the whole time, but the X-ray isn't sensitive enough to pick it up. So even if you get a negative X-ray, but the person is saying clinically, they're saying all the right things for having a stress fracture, then that's when we advocate for them to get an MRI or a bone scan in order to be able to be a bit more sensitive and specific in trying to find these stress fractures. So because imaging can't help us a whole lot, the diagnosis is often a clinical one, that we kind of go off of our gut feeling on this person saying everything that would be consistent with a stress fracture. And as a result, we're going to say that you have a stress fracture, regardless of what imaging tells us. And so the treatment ends up being more so education-based, where we suggest to the person, hey, I want you to avoid running. So you're going to shut it down. You're going to cross-train, so bike, swim, do something other than running. You can do some light resisted exercise, but otherwise no impact. And I want you to do that for 2 or 3 weeks. We're going to meet up again. Maybe we'll play around with some of the biomechanical factors that might have led to this, and then otherwise really slowly reintroduce activity back into their life. It's not one that gets fixed with surgery. It's not one that gets fixed with any sort of medication. It's one that gets fixed with us just knowing what's happening and communicating that to the other person and hoping that they comply to your instruction. With stress fractures, it's really important to screen for something called relative energy deficiency in sport, or REDS. We used to call this female athlete triad, but we know that it's far more complicated than it being exclusively related to women or being a triad or affecting only 3 aspects. So here's what relative energy deficiency in sport is all about. Before, we used to call it, again, the female athlete triad, where we would have disordered eating, we would have decrease in bone health, and then we'd have decreased mental function. And we used to think that was all that this had to do with it. But in reality, what we know is that when we decrease our energy intake relative to our energy output, is that we end up getting a deficiency. This either occurs to athletes that are endurance athletes burning 5,000-6,000 calories a day, but only eating 2,000 calories a day, that essentially they're losing or they're in a massive caloric deficit. Or in the event that they might be working out at a decent level, so nothing too crazy, but they're restricting calories a whole lot. And we'll end up seeing that in aesthetic sports such as swimming or gymnastics or dance, where or wrestling, where a particular weight class or a particular physique is deemed kind of better. And so as a result of this deficiency, whether overtraining or undereating, then we get a whole host of injuries that occur. Why I'm bringing this up to you is that we get bone health changes. So we get, essentially, we'll get 20-year-olds who are elite and national ranked runners that should be fittest and healthiest out of all of us, end up getting osteoporosis at 20. That will lead to stress fractures. So huge influence on bone health. We'll also get influence on menstrual cycle. So then they'll become what's called amenorrheic, or they'll have no periods. And so this leads to fertility issues. Based off of what we talked about earlier on the influence of estrogen on bone, that us influencing our hormonal state will affect menstrual function, but also that decrease in estrogen will also influence bone and then feed into this cycle. But now what we know about REDS is that it influences a whole host of other issues. It causes endocrine issues, so hormonal issues that also feed into fertility issues, causes changes into immune function, psychology. They end up becoming anxious and develop eating disorders and psychological depression, anxiety, all that stuff, and a whole host of other issues. And so it's especially important to educate athletes who are in these high-risk sports, endurance sports or aesthetic sports, to identify if they might have this relative energy deficiency. If they do, really important to refer them on to a sport medicine doctor who can do a full blood panel on them and identify what deficiencies they might have: iron, hemoglobin, etc. or refer onto a registered dietitian who can then walk them through of how to build up their caloric reserves again so they're not sitting in a deficiency. And then I, as a physiotherapist, is another member of the team who will then help to reintroduce exercise back into their life once it's deemed appropriate. So that's a kind of a less traumatic, but very functionally debilitating result of low bone mass. So here we go again. We survived another week. So good job. This week we have another quiz, as always, due on Sunday at 11:59 p.m. We also have office hours at Tuesday and Thursday, 10 a.m. to 11 with me. And then from 2 to 4 on Wednesday with Alex Noonan, our TA. And so if you need anything, reach out. Again, I appreciate all the feedback that you've given up until this point. I hope you appreciate the changes that have been made, and then otherwise have learned a ton about bone. So until next time, keep well, guys.